Yeah, ma'am, you can proceed with your trial one,
Okay.
or I can say the demo. Yeah.
Hello, good evening,
And sir,
everyone.
I have shared the link with you. What, ma'am?
Yeah, shall I start? Like,
Yeah, yeah, yeah. Yeah, you can.
hello, good evening, everyone. I'm Dr. Ramya, your radiology educator in Medico's community. Today, we'll be discussing the most important 25 radiology questions. So, let us start the session without much further ado. Um, the first question is the easiest one. On Friday, 8th November 1895, W.C. Rongen was reproducing earlier work using low output Leonard tubes where fluorescent where is only taking raw option and I need to change this. Um, where fluorescent rays were seen on the screen coated with barium fluorocyanide. What were those rays? Obviously, the answer is X rays. So, let us see how they are produced. This is anode, which is made up of tungsten. This is cathode. This is also made up of tungsten filament. These cathode and anode are connected to a voltage where the electrons are produced from the cathode and they form a space charge around it, which is by a process called thermionic emission. These electrons hit fast moving electrons hit on the anode, that is the target, in a slant way, because if there is a this is called anode angle, and when the electrons are hitting on the target, 99% of them are producing only energy. 99% of this energy is converted into heat, and only 1% is converted into x-rays. So this 1% of the x-rays, whichever is converted, this x-ray beam is read on to the detectors. Depending on whether it is DR or CR or whatever we are doing, the detector's composition changes. So after the detectors detect the X-rays, this is connected to a monitor onto which we'll be able to see the image. So the other parts of the X-ray tube, which is important for our MCQ purpose, is that is there is a window, and the entire apparatus is enveloped in a glass which is filled with vacuum. Why vacuum? Because if the electrons are moving in the air, there is a friction which is created. If it is in the vacuum, then there is no friction and there will be no problem, and less amount of energy wastage will be there, and the entire apparatus is inside a lead casing or a metal casing, and there is oil for heat conduction. As we have already discussed, 99% is coming out as heat. So this heat will cause other problems, such as much heat is given onto the anode, there will be damage to the anode. So to reduce the damage to the anode, we are conducting the heat through oil. Oil is passed through a small tube outside this thing, and also there is another way of heat dissipation, which is called as radiation. Maximum it is through radiation only, and the rest of it is through conduction through the oil. Coming to the next question, what is the sign in this image and the condition? So, any image based question, the first thing you have to see is, first we will see about the anatomy of whatever is given to us. So, obviously, this is heart. Use a different color. So, this is the boundary for heart, and this is the descending thoracic aorta, and this is the esophagus here. There we are able to see the air. Anything which is dark in CT, it is air. That the lungs, right? And this is the thoracic vertebral body. These are the ribs. Here we are able to see there is a two lines are there where we are able to see a fluid density HU. So first we will see what is there in CT. What are the different types of HU that we are able to see here. This is bone HU, which is the brightest, that is white, and this is air, which is corresponding to almost minus 1000 HU, and this is lungs. In lung window we will be able to see in minus 400 to minus 600. Okay, and water, which is almost at the zero. So this is the brightest amongst all. This is the plus 1000 bone, and air is minus 1000. So this is of water HU, which is there between the parietal and visceral pleura. Coming to the options, let's see all the anatomy first and then we'll go to the pathologies. This is a chest x-ray of a neonate. Here we are able to see there is a structure which is radio opaque, and we are able to see the outlines other than the lungs and the heart in a way of Spinnaker sail sign seen in normal thymus of a neonate. Next, coming to the axial sections of the CT, we are able to see that there is air encompassed here. This is pneumomediastinum. And next, here we are able to see this is an adult chest x-ray where there is bulging of the fissure. There is a radio opacity in the right upper zone, and there is a bulging of the fissure which is characteristic for Klebsiella pneumoniae. So coming to our question, this is split pleura sign which is seen in emphyema. It is slightly denser than water, but it is almost of the fluid density. So we are able to say it is emphyema. So which is visceral and which is parietal pleura here? This is visceral pleura and this is parietal pleura, because visceral pleura covers the lung and the fluid is accumulated between the visceral and parietal pleura. That is the definition for pleural effusion. As well as for emphyema, that is pleural effusion and emphyema, both of them we'll be able to see in between the visceral and parietal pleura only. So this is Spinnaker sail sign. This is bulging fissure sign from Klebsiella. And coming to this, another option which we have here, this is an overexposed film. So when you see such film, we have to compare it with the air here. So here the air is outside the thorax. Here inside the lung also it is like this only in the same manner. So you should not get confused that this is some pathology. That is why I've purposefully put it here. So this is the arch of aorta, and this is the heart border. This is the right dome of diaphragm and this is left dome of diaphragm, and the thorax and ribs we are able to see here. The most important thing here is there is a thin radiolucent area just around the arch of aorta, and there is a hilar mass. So this is actually a left upper lobe collapse. The upper lobe of the left upper lobe is collapsed. There is a V-like opacity on the left upper lobe. The lower lobe is expanded and it is covering just around the aorta also. So this is the lower lobe which is normal, and this is the left upper lobe which is collapsed and arching around the lower lobe and the arch of aorta, which is causing the Luftischel sign, left upper lobe collapse. Next question. Lead pipe colon is seen in which condition? Okay, this is the spinous process which we are able to see here, and this is the liver shadow. The psoas shadows are seen here, and this is the sacrum, iliac, and the hip joint. This is the sacrum. Okay, coming to the pathology, this is the featureless loss of ostrations are there. That it is looking just like lead pipe. So what are the signs which we see in ulcerative colitis? Let us have a quick look. So, ulcerative colitis is particularly seen. Rectum is must be involved if we are calling it as an ulcerative colitis. In Crohn's disease, terminal ileum is more involved. Symptoms have bloody diarrhea and crampy abdominal pain, but specific for ulcerative colitis is bloody diarrhea, and for Crohn's disease it's crampy abdominal pain. Thickness of inflammation, submucosa and mucosa is inflamed in ulcerative colitis, whereas transmural, the entire the thickness of mucosa, submucosa, muscularis propria, everything is involved. That is transmural involvement. Only submucosa is involved in the ulcerative colitis. The complication is for ulcerative colitis is hemorrhage and toxic megacolon. Toxic megacolon means the colon is greater than 6 centimeters. Crohn's disease, there will be fistulas, abscess, and obstruction within the bowel, which will cause complications. Cytokine response is with Th17, and here it is with Th2. Distribution is continuous. That means the entire bowel is involved in transmural, in submucosal and ulcerative colitis, and it is discontinuous. That means there are skip lesions. There will be skip lesion. There will be some amount of involvement here, and then there will be a no problem, and then there will be another lesion here. That is discontinuous. So the drugs used are totally different for ulcerative and Crohn's. That we can cover in medicine. So next, which of the following is the best radiological investigation in case of splenic rupture? CT, MRI, X-ray and ultrasound. So what is the purpose of X-ray? X-ray, we see if there is any bone injury. That is the most important thing which you have to remember. And then for fluid and free fluid, hemoperitoneum, air, we will be able to see ultrasound in a better way. For bone, again, X-ray and CT work on the same principle. For CT, we use it in bone and soft tissue. Okay. For MRI, it is the most amazing modality where you will be able to see the soft tissue in a very proper way. The soft tissue delineation and characterization is unremarkable in MRI. So here they're talking about the spleen. So let's see the normal imaging guidelines for abdominal trauma first, and then we'll go to the answer. If hemodynamic status of the patient is the most important thing in a case of abdominal trauma. If the patient is unstable, we are supposed to do fast, that is ultrasound, focused SS sonographic in trauma, chest x-ray, pelvic x-ray, and CT is not appropriate if the patient is unstable. If the patient is stable, we'll go for a fast, and if it is positive, that means if you are able to find any fluid in the uh, fast, we will go to the zigzag manner. So first subxiphoid space, we will see the heart if there is any pericardial effusion, cardiac tamponade, or if there is any free fluid within the uh, pericardial sac. And also after the subxiphoid space, we'll go to the right hypochondrium, where there will be Morrison space between the kidney and the liver. So this is the most dependent position when a patient is lying supine. Even a small amount of fluid, if it is there, even a small amount of hemoperitoneum, we will not miss if we are looking in the Morrison's pouch. Okay, and then next we'll go to the left hypochondrium, where we will see the spleen, the contour, and kidney if there is any laceration or subcapsular hematoma, and if there is any other external injury in case of blunt trauma. And then pelvis. In pelvis, we will in females we'll see the pouch of Douglas, where there will be fluid accumulation, and also we are supposed to see the right and left paracolic gutters, because that is also a potential space for fluid accumulation. Okay, this is all what we see in fast. If if there is any finding in fast, it is positive, then we have to go for CECT. In CECT also, there is delayed scan at 5 minutes if there is renal injury, and immediately repeat the CT in region of interest if there is contrast flush. CT cystography is indicated in pelvic fracture because we will be looking for extra or intraperitoneal rupture of the bladder. If it is extraperitoneal rupture of bladder, there will be contrast extravasation only anterior to the bladder. If it is intraperitoneal rupture of bladder, then we'll be seeing contrast with between the bowel loops also. Next, if the fast is negative, we didn't find any of this, and we have to observe. If there is any hemodynamic instability, if the patient is not stable, then we have to repeat the fast. So, coming to our question, which is the best radiological investigation in case of splenic rupture for bone and soft tissue and solid organs? As we have discussed, CT is best. Next, identify the condition. A scurvy, B rickets, C lead poisoning, and fluorosis. So, what are we seeing here? Definitely, it is a immature skeleton because all the carpal bones are not here, and there is cupping and fraying of metaphysis in both radius and ulna. So, this is a case of rickets. The other findings which we will be able to see in scurvy are subperiosteal hemorrhage because of the deficiency in vitamin C. There will be subperiosteal hemorrhage, scorbutic zone, and a dense zone of provisional calcification. There is a ring epiphysis, Wimberger ring sign. This is also a differential for congenital syphilis, but it is more specific for scurvy. There is Pelkian spur. So this is for scurvy, and we are able to see dense radio opaque bands in the metaphysis region of an immature skeleton. This is a case of lead poisoning, but the differentials for this condition is resolving rickets. Once we start giving vitamin D, even resolving rickets also looks like this only. So we should be careful in labeling it as lead poisoning. We are supposed to know the history also. Next, coming to fluorosis, the classical feature for fluorosis is there is interosseous membrane calcification. This is the interosseous radio ulnar interosseous membrane in which we are able to see the calcifications. Okay, this is a lateral and oblique view of the forearm where we are able to see the interosseous membrane calcification. What is the sign and condition? Mount Fuji sign, tension pneumothorax, figure of 8, lissencephaly, molar tooth, Jobert sign, salt and pepper paraganglioma. So even if you don't know the answer, it is easy to guess in such questions that it looks like it looks like a hill. So it is Mount Fuji sign, which we see in a tension pneumothorax. In normal pneumothorax, you'll not be able to see the Mount Fuji sign. Only in tension pneumothorax, because the air is filled in and there is no a way for it to go outside, it causes compression over the cerebral cortex, which causes this Mount Fuji sign. So, regarding the rest of the options, let's have a look at the images. This is an infantile axial section of the CT where we are able to see smooth cortex, which is giving an overall appearance of 8. So, this is lissencephaly, figure of 8 appearance. There is dilated ventricle, and there is a loss of gyri and sulci. They're not formed itself. It is a congenital anomaly. Next, coming to Jobert syndrome, where a molar tooth sign is seen. This is the elongated superior cerebellar peduncle, which is almost looking like a molar tooth. Okay, and also in Jobert syndrome, there is bat wing appearance of fourth ventricle. These two are important for Jobert syndrome. For some reason, such syndromes are very popular in NEET exams. So, next, popcorn calcification is seen in pulmonary hematoma, pulmonary hemorrhage, pulmonary teratoma, and pulmonary embolism. These kind of questions are also popular in radiology questions for NEET, because in normal time when we ask somebody, they'll definitely tell it is pulmonary hematoma. When they see all of these MCQ questions and all the options, it becomes very uh, confusing. So for one other trick to solve the MCQs is just look at the question, don't see the options, try to answer it without looking at the questions. Maybe you will get to a clarity before answering them. So that's why I put this question. This is pulmonary hematoma, and there is a classical popcorn calcification seen on the axial section of the CT lung. Evidence nodes are found in PIP joints in osteoarthritis, DIP joints in osteoarthritis, PIP joints in osteoarthritis, and DIP joints in rheumatoid arthritis. This is the most high yielding topic, so please pay attention. Hubbard's nodules are found at the distal HD. This is how you're supposed to remember, because some things are better. You're not supposed to make a mistake. Distal interphalangeal joints, Hubbard's nodules, and Burkhart's nodules are seen in the proximal interphalangeal joints. It is BP. So the radiological representation. These are the Hubbard's nodules, and these are the Burkhart's nodules. Coming to an overall areas where osteoarthritis is more involved and rheumatoid arthritis is more involved. Um, Osteoarthritis and rheumatoid arthritis both will be involving commonly the distal interphalangeal joint of first, and all the all the fingers, and proximal interphalangeal joints of, sorry, the proximal interphalangeal joints and distal interphalangeal joints are involved in osteoarthritis, and also the metacarpal phalangeal joints are also involved. In rheumatoid arthritis, for only thumb, distal, and proximal interphalangeal joints are involved, and for the rest of the thing, metacarpophalangeal joints and proximal interphalangeal joints, and ulnar side of the carpal and radial ulnar aspect of the wrist joint is more involved. So this is a normal hand, and in case this is rheumatoid arthritis where there are bone erosions and bone is displaced towards the radial aspect. This is classical for rheumatoid arthritis. The other important thing for to look for is, if there is soft tissue mass around the joint, then we have to think about gout. If there are punched out lesions and erosions, we have to think about psoriatic arthritis. If the joint space is preserved, um, we have to think about osteopenia. But in later stages, if osteoarthritis is there, then we have to think about osteoarthritis as well. Most of the features are overlapping, but soft tissue tophi are confined to a diagnosis of gout only. Next, what is the most likely diagnosis in this case? Extradural hematoma, subdural hematoma, subarachnoid hemorrhage, and sciura. So we are able to see this is the orbits, and these are the ventricles.
Mm.
The right
So,
ventricle is pushed.
stop.
Okay.
Yeah, you have gone till ninth question. So, Sagar, are you there?
तो कौन टा खाइबू Hello.
Yeah. Sagar,
Yeah.
hopingly the thing is she has gone till ninth question and we have checked it for 15 minutes, I feel.
Yeah.
So, what I felt is with respect to technical, first of all, you say something related to technical. Later onwards, I will proceed with what it is related to radiology.
Actually, the thing is that, na ma'am, Right now you are in the good network place,
Yeah.
or it's not.
Yes, I am in good network place.
Have you connected it to
Yeah.
Wi-Fi?
Yes, I am connected to Wi-Fi only, sir.
Actually, the
Okay.
thing is that, na ma'am, we are, yeah, ma'am. So we are getting some s- slow gestures.
Okay.
Yeah. So we need a good network connection for this.
Okay.
Yeah.
I'll try to top up or increase the speed.
Yeah. Please do this. Yeah, sir, you can continue.
Yeah. So, in the sense, regards to presentation, Ramya, I think that you should be more this one interactive with the students
Okay,
by tomorrow when you present the particular radiology session.
sir.
And the thing is something like your explanation is good. There is no issues. Like there is a scope for the improvement in the for the future.
Yes, sir.
For the first session, we can give a compromise with this, but in the upcoming sessions, I think that there needs a lot of improvement over the areas, and I'll be discussing in the for the future.
Okay, sir.
And obviously while you present the session, no, it should be something like when you get off, I think that as it is a demo session you haven't gone through those things, but when you present in the future in the live session in the front end screen, you are supposed to take something like if you have seen the live sessions of the previous faculties, that they have said something related to medicos community and something related to that, and they have said something related to early bird offer of the medicos community.
Okay, sir.
And they said something, that as you have did the product promo video, the early bird offers are live in this particular website, and you can visit there and you can get those early bird offers before the slot runs out, something like that they said. And something you should say something like, as your session is not a single session for 25 questions, you should make target audience that be aware of the two sessions as well
Okay, sir.
before you proceed ahead with the first question. I feel like something you say the session is two sessions we'll be taking, and this is classified into 12 plus 13, and we are discussing the 12 questions in this particular sessions. So that shall we proceed with the first question? Something it should be like that, and always something we don't expect a very huge audience in this particular session, as it is a first session I can say, but still what we need to follow the thumb rule with
Yes,
each
sir.
and every aspect what we follow.
Yeah.
Like it should be this one, they should not be compromised with the quality anywhere,
Yes, sir.
and there should not be something like we miss the interactive, because what we do is we, there may not be very big huge audience for this live session, but obviously they will see these live sessions in the future.
Yes, sir.
When they see this live session, it should not be something like wrong, something like they have compromised with the quality, they have compromised with the something else.
Yes.
So something you should keep these aspects in the mind. And once again, I don't know what is the timings by tomorrow. Once again, we need to check with this network. You top up that particular network, you speed up that particular